So I'll be speaking next on myopic tractional foveoschisis, some management pearls, some tips and tricks in the surgical part. I have no financial interest in any of the products used. So just a brief, pathological myopia is by definition globe elongation and a refractive error of at least 8 diopters or axial length of greater than 26.5 mm associated with the degenerative changes in the retina. And uh, as you might know, pathological myopia has a high disease burden, almost 30 to 40% of patients having more than minus 8 diopters of myopia have myopic foveoschisis, and excessive uh, axial elongation results in mechanical stretching and thinning of the choroid, leading to staphylomas, RP atrophy, lac cracks, CNVM, foveoschisis, and finally myopic macular hole. So, coming directly to the surgical part. So, surgery in these cases are complicated. There is no standardized technique, and the results are suboptimal. And as routine, as you know, in difference to the routine vitrectomies, there are few unique challenges to surgeries in high myopic eyes. The first is visualization. The second is PVD induction. The length of the eyeball, because the routine instruments which we use are not meant for excellence of more than 30 millimeters. And finally, a common technique which can yield, a constant surgical results. So coming to the first point, visualization. So I've seen in my experience, and it's been reported in literature also, that a small amount of lenticular changes also create a huge amount of aberrations in these cases. So even if the patient is young and 40 or 45 and has few lenticular changes, it's always good to do a combined case or in a stage procedure, whether you're comfortable in a stage or combined, but do a phaco-vitrectomy and do the peeling part or the vitrectomy part at a later stage. It gives you a very crisp contrast to the already poor contrast of the choroid, and you can peel the LM in a more confident way. So the first thing is, if there is a slightest amount of cataract in these patients, you do a phaco-vitrectomy or do a stage procedure in these cases. The second part is PVD induction. So as we all know, there is vitreoschissis in these cases, and the axial length is long, and so it's not a routine PVD induction as we do in normal eyes. So the first way of doing is to categorize whether it is less than 30 mm or more than 30 mm. So if its eyes are around 28 to 29 mm of axial length, you can just do a core vitrectomy, inject PFCL, and do a PVD induction with the help of ILM forceps. You can inject more PFCL in the well you have made. So this is, I'm doing a bimanual technique, and enlarging that cleavage plane with the blunt end of the endolite. We have used a lot of this technique in pediatric cases also, and it works wonderfully well in these cases also, because this hyaloid is actually very stuck to the retina, and it will not come out with a cutter. The second part of this technique involves patients who have axial lengths of more than 30 mm, and these eyes are really difficult. And if you inject PFCL in these cases, actually the axial length pseudo enlarges, so it's not a good idea to inject PFCL. So here the only thing is patience, patience, and patience. You use a combination of instruments, you use an end gripping forceps, you use mild section from the cutter, and in the hope and that some cleavage plane you'll get hold of, and you will induce the PVD. There's no other way around it. So you have to do it. You stain it multiple times with triamcinolone acetonide, trypan blue, and make sure that the posterior pole is stained and no amount of cortical vitreous is left at the posterior pole. The third point, the length. So there are many ways to circumvent the high axial length. You have to make posterior trocars. You can go to 4.5 mm, and you can remove the cannula part to increase your maneuverability. The most important part is using the imaging system, the viewing system. So again, if you divide it into two parts in the very high axial length of more than 30 mmHg, it's a very good idea to use a irrigating lens or a macular lens. The point here being is that in a high axial length, when you're going inside with the forceps, actually your forceps is vertical. And when your forceps is vertical, the shaft of the forceps touches the rim of the non-contact viewing system, and it can create to a lot of aberrations and jerky movements. So the macular lens provides excellent resolution and good magnification, and in these cases where the axial length is so high, you should use a magnifying lens. These are excellent things. Otherwise, you can and do away with the normal non-contact wide angle systems. So we have posterior trocars, we have magnifying lenses. The other way is you can, if you are bidextrous, you can use a left hand. So the ILM was not approachable with the right hand. So in this case, I'm using my left hand to the peel ILM. So you have to use, multiple ways to come to the posterior pole with your routine instruments. Of course, there are customized forceps in my OT, which I have made to do these cases. But using all these techniques, we all know these have been described in literature, still recurrences do happen. And the primary reason is the incomplete removal of hyoid, the proliferation, and the incomplete closure of hole. And this is a case operated somewhere else. It was operated for a high myopic macular hole or a traction maculopathy, and he developed a RD, and we operated. And you can see here, the best dye to use here is the blue dye, the trypan blue. Tricot will not stain much of the cortical vitreous. And as you can see, under the PFCL, we are peeling the ILM after the hyaloid has been removed, stained by trypan blue. And even if the retina is attached, there are frequent cases of type 2 macular hole, which is actually a suboptimal result. So what is the technique which we should follow, or which can yield relatively consistent results? So this is a case history of a patient. Is a one-eyed patient with vision of finger counting close to face, axial length is around 30, and she's a pseudophakic, and she has a myopic Foveoschisis with a macular hole. So this is what we have been following for the past couple of years, past 3 to 4 years. And this is a small animation showing, first you make the trochas around 4.5 to 5 mm E1, you will not go through the retina. The maneuverability becomes very easy. You can, with the routine instruments, you can reach the posterior pole very easy. You stain the hyaloid. There is no two ways around it. You have to have the patience in this step. You have to, induce the PVD and then stain and then inject a small amount of PFCL. And the thing is that there's a lot of posterior pole fluid in these cases. So you do an inverted ILM flap technique, what you do routinely. The only difference being here is that it should be wide based. And that will, avoid you additional retinotomy to drain the posterior pole fluid. So coming to the real actually surgical video. So this was the case, and you can see the boggy posterior pole. There's a lot of fluid. There's a macular hole there. And the first step is PVD induction after making posterior ports. After that, you stain with trypan blue to see whether there is any residual cortical vitreous left or any ERM left. Once you think that there is none, you stain it with brilliant blue, multiple stainings, multiple times, and for a longer duration. You inject a small bubble of PFCL and make the posterior polar relatively flat before injecting a small bubble of PFCL, and then you start peeling. The difference here between the routine peeling, the routine inverted peeling, and the peeling in these cases is it has to be of a larger diameter. The peeling extent should encroach the excavation of the staphyloma, because you have to make the retina sufficiently redundant so that as to close the hole. If you are peeling and you have peeled a small area, it will not be pliable enough, and there will be recurrence, a late reopening of the hole, or a type 2 closure. As you can see, the extent of the peel is more than the inverted peeling in macular holes, and it's reaching that edge of the macular, of the edge of the staphyloma. And that is the key to success in these cases. The second benefit of this technique, as I told you before, that you don't have to make additional retinotomy. That fluid, because of the PFCL, has shifted to the periphery. The posterior pole is flat, but by the next 2 days, the whole posterior pole will be flat. There will be no subretinal fluid, provided you have not missed any other break, any slit breaks near the vessels. And once you aspirate the PFCL, this technique is so stable, the flap is so stable, it will not get dislodged after the PFCL bubble has been removed. This is the OCT follow-up of this case. This is the fundus picture pre-op and post-op. So to conclude, lessons learned over the years are MTM is a complex surgery with varied intraoperative surprises. A thorough preoperative workup and planning is needed. Multiple steps are useful in the surgeries, like doing a phaco-vitrectomy, doing PVD inductions with with the combination of dyes, multiple stainings for a longer time, posterior ports. But the bottom line is a thorough preoperative counseling with a very clear communication about the chances of failure, reopening of holes, and modest improvement of vision should be done to the patient and their relatives. Thank you so much.
Yeah, thank you, Dr. Vishal, for excellent presentation and video. and they are very challenging cases of use cases. But, which are the case you feel like to operate early, or you decide on
There's
what
no point in
criteria?
touching these patients if they have ambulatory vision and a good navigational vision. If the only indication of surgery is a progression and a deterioration with serial OCT follow-ups, you might see a significant fluid and a significant traction in the OCT, but the patient still might be comfortable. The patient tells you, like Dr. Lal said, that the vision has gone down and he or she is not able to do the daily activities now. Then you touch these eyes. These are complex surgeries.
And how many months you have follow up? Because many time it takes time for regress the schisis, or because your pictures is showing that in 15 days it has become flat, but in few patients it take longer time also
So
in
I think if,
Foveoschisis.
if you if you don't have any other hole and you do the inverted ILM flap in these cases, around 6 weeks or 8 weeks, the fluid resorbs. Even if the RP is very unhealthy in these cases, as it is.
Great, yeah, sure, thank you. Any other